Hey there, Toby Stark Associates Insurance Agency. It's almost that time, Medicare beneficiaries. It's almost the start of the season. What season is that? It's the annual election period, or AEP, from October 15th to December 7th. You're going to hear me say this over and over again. Well, what is AEP? If you have a drug plan, which is Part D of Medicare, so there's an umbrella. The umbrella is over Medicare. So Part D is where all the private maintenance medication carriers, the drug plans, play to offer you insurance coverage. And every year there's an election period, October 15th to December 7th, which gives you the opportunity to change your drug plan in that window for an effective date of January 1st. Effective date meaning that's when it takes effect. So there are, hot off the presses, some updates on Part D and what is going to be your expected out-of-pocket cost potentially for you. There's always confusion around this time period because many of you that are listening to it have a Medicare supplement policy that works with Medicare to take care of your medical care, not drug care. And a lot of people think that that's when their supplement renews as well. And unless your Medicare supplement renews between October 1st and January 1st, then it may well be. But a lot of you, there's still 3/4 of the year left where your Medicare supplement renews on the effective date in which you enrolled, which does not coincide with the annual election period. We're focusing on the drug plan. Okay? So I'm going to get into the details for what 2024 looks like for you. And please, we're going to send a form out to you for you to fill out your updated maintenance medications, send them to you. We'll review them in the office and make a recommendation if you should change your drug plan or stay on your drug plan. Why would you change? Well, we search by lowest premium cost per insurance carrier. And oh, by the way, there's probably approximately 25 to 27 drug plans in your area, depending upon where you live. So we're searching by lowest premium, or what you pay for the insurance plan for your drugs every single month. And also we're searching by lowest out-of-pocket cost for your maintenance medications, because as I've said to most of you, why would you pay $1 more for a generic med when you don't have to, right? And then also what we're going to do is search your pharmacy. So make sure to include your pharmacy so we can search that pharmacy. Depending, we may search another pharmacy to make another recommendation. There can be savings had between pharmacies depending. There is cost transparency as a Medicare beneficiary, so you can see what the costs are and you can anticipate what your out-of-pocket costs are going to be. So let's get into it here. So this is the true out-of-pocket costs of Medicare Part D. And before we get into it again, what I want to let you know, you're going to see some big numbers. A lot of these numbers aren't your responsibility. They're Medicare paying for it on your behalf. They're the drug plan paying for it on your behalf. Or in some cases, it's a rebate that the pharmaceutical company has. So don't think that, oh my goodness, I'm going to have to pay this whole amount. It's a combination of all of it. And generally, you're going to be paying the least amount. So there are different stages for Medicare Part D, and this will be for year 2024. There's the deductible stage, the initial coverage stage, the coverage gap, which everybody calls the donut hole. A couple of years ago, that they've closed the donut hole. Congress has closed the donut hole, and they talked about closing it for about 15 years, and then the donut hole is closed. So now it's called the coverage gap, which still means there's still some responsibility for you. So anyway, donut hole, coverage gap, donut hole's gone. It's the coverage gap now. And then ultimately, and only about 5% of Medicare beneficiaries get here, but 100% of people worry about it. Catastrophic coverage, the last stage, and then the plan year restarts. The last stage of your true out-of-pocket costs. So where do you start? You start on January 1st at the deductible stage. You are responsible for 100% of your prescription drug costs until your deductible is met. Your plan may have an annual deductible of no more than $545. There's some plans that have less deductible. Some plans carry a $0 deductible. In some plans, the deductible may not apply to certain low-cost or generic drugs. That is true because sometimes those generic drugs are so inexpensive, it's actually included in the premium you pay. So it's free when you go pick up the blood pressure medicine. Any of the run-of-the-mill common maintenance medication generics that are tier 1 will be covered generally at 100%, depending upon what the insurance carrier's appetite is for that coverage. Once you meet your deductible, if you have one, and remember, a deductible is your financial responsibility first before the insurance carrier does anything, okay? You would enter the initial coverage phase. You pay a copay or coinsurance. Most of us know what a copay is. Most of us don't know what coinsurance is. Coinsurance is the sharing of costs. It's a percentage between you, the consumer, and the insurance carrier. Your Part D plan pays the rest of prescription drugs included on your plan's formulary or list of covered medications. So you can see they're stepping up here. So that's what we do. We ask for you to send us your maintenance medications so we can make a recommendation and review for January 1st. Next, and some of you that are on higher cost maintenance medications may get here. A lot of you will not. A lot of you will probably wind up the entire year here. Some of you, though, may hit the coverage gap, and you could see this person's leaping across the drug pill packs. After you and your plan have together spent, after you and your plan have together spent $5,030 on prescription drugs, then you enter the coverage gap. Now you pay 25% of the cost for both generic and brand name drugs, plus a small pharmacy dispensing fee of about $1 to $3. And take a quick drink. We're only 7 minutes in. All right. So, and next is catastrophic coverage. Okay, that's the last stop. After your true out-of-pocket costs for prescription drugs reaches $8,000, and this is the important point, including manufacturers' discounts. When they discount the maintenance medication drug, the full amount will still be applied to true out-of-pocket, but you're not paying it. And guess what? You only care about what you're paying, right? As you should, including manufacturers' discounts on brand name drugs. You no longer face any cost sharing for the rest of the year. This is wildly different from years before, where when you entered the catastrophic coverage portion, you would have to pay either a small copay or a small percentage of that maintenance medication up to nothing, because there was no ceiling. There was no maximum out of pocket. And this is part of the Part D reform, where now they are introducing a maximum max out of pocket. I wish I could talk to that. Or MOOP. It's a true out-of-pocket maximum, $8,000. That again, manufacturers' discounts, brand name drugs they all add up to that $8,000. You will not be paying all of that money. And then the cycle resets. Plan year restarts. Now in 2025, when I do this again, you actually have a maximum out of pocket of $2,000, not $8,000. That's going to be great for the Medicare beneficiaries, but how much are going to cost you? How much are the drug plans going to charge? How much are the premiums going to be in 2025? And again, there's a law that was passed that will cap the increases year over year for these carriers to only 5%. So I just want to go over quickly tier level classifications because you're going to see this when we do the review. Tier 1, preferred generic. This tier consists of commonly prescribed generic drugs. Beneficiaries pay least for the drugs in this tier. Tier 2 is generic. Drugs in the tier are generic and slightly more costly than those in Tier 1. And this is generally where a lot of people are. They live here in preferred generic and generic. Tier 1 preferred generic, you would be on your drug plan and you may not even see a cost for these. It'll be dispensed and it's embedded in your premium that you pay for your drug plan. Tier 3, preferred brand. This tier consists of brand name prescription drugs without a generic equivalent. They're lower cost than conventional branded drugs. They are, but it's going to start pumping up your out-of-pocket cost. Tier 4 brand. Drugs in this tier are brand name and do not have a generic equivalent. They're typically more expensive than those in Tier 3. And Tier 5, which is the most expensive tier, is specialty. The tier consists of high-cost specialty drugs that treat complex conditions like cancer. They may be generic or brand name. Beneficiaries typically pay the most for drugs in this tier. So most folks that are here, you'll never get to the coverage gap. Here, possibly, and here, definitely, you would go through to catastrophic. The plan coverage rules, some of you may have experienced this. Prior authorization. Prescription drug plans with prior authorization require a physician to get advanced approval before a specific medication can be prescribed to a plan beneficiary. Step therapy. As Medicare.gov explains, step therapy is a type of prior authorization. In most cases, you must first try a certain less expensive drug on the plan's formulary that has been proven effective for most people with your condition before you can move up a step to a more expensive drug. For instance, some plans may require you first to try a generic drug, if available, then a less expensive brand name drug on their drug list before you can get a similar, more expensive brand name drug covered. And the reason why they do this, it's cost containment guardrails too. Quantity limits, and it's for safety and cost reasons. Plans may limit the amount of prescription drugs they cover over a certain period of time. For example, most people prescribed heartburn medication take 1 tablet per day for 4 weeks. Therefore, a plan may cover only an initial 30-day supply of the heartburn medication. Sometimes there's a coverage exemption. As CMS.gov explains, coverage exemptions can be requested to obtain a Part D drug that is not included on a plan sponsor's formulary, or to request to have a utilization management requirement waived, step therapy, prior authorization, or quantity limit, for example, for a formulary drug. And coverage cost methods. Premiums is a periodic payment to keep an insurance policy in force that I explained in the beginning. A deductible is the amount of covered expenses that an insured, you, must pay before a plan or insurance contract starts to reimburse for eligible expenses. We're all copay experts. A fixed amount a beneficiary pays for coverage medication, and coinsurance, the percentage of costs for which a beneficiary is responsible after he or she has paid a deductible. So I am going to send a copy of this out to everybody in email. I'll also put this up on my channels at Toby Stark on YouTube, and I'll have it on my website as well for you to review. This is important to know how the steps work. I'm not asking you to be an expert in this. You can keep it on hand. And when you go to the pharmacy, if there is a cost discrepancy or a change, you might have changed levels as you march through the Part D steps. Some of you might wind up in the coverage gap. So that's why you might be seeing an increase. Thanks again. Toby Stark, Stark Associates Insurance Agency. We're here for you through the annual election period, which is October 15th to December 7th and beyond. Happy to help. Take care.